Thank you for the opportunity to discuss hand dermatitis. I'll also include foot dermatitis, but I think we all agree in the clinic, this is one of the more vexing issues that we have to deal with when patients walk in with some dermatitis and inflammation of their hands and or their feet. These are my disclosures. And hand dermatitis represents a pretty broad diagnosis. If we just think of hands that are inflamed overall, it affects 5 to 10% of the general population. And not surprisingly, healthcare workers, those exposed to wet work where their hands are always wet or intermittently getting wet, frequent hand washings, and a history of atopic dermatitis are all risk factors for getting hand dermatitis. And I mentioned AD, which is one of the top risk factors. There's a number of reasons why patients may present with hand dermatitis. It may be interfering with their activities of routine daily living or capacity for working. It may itch or be painful. There's a number of causes. It could be irritant or allergic contact dermatitis from outside sources. It could be endogenous. These patients could have psoriasis. And I think generically, when we look at someone, it may not be easy to diagnose psoriasis just on the hands and feet. One needs to do a total skin check to look for stigmata of classic psoriasis. Dyshidrotic dermatitis is not an outside source, but sort of an inside job related to eczema. Atopic nummular dermatitis, id reactions can all occur, but rarely is hand dermatitis a pure play of just one thing. Even the pure psoriatic palmoplantar psoriasis patient, the pure atopic dermatitis, they often have some irritant or even allergic contact dermatitis involved. For eczematous dermatitis, it can also be quite heterogeneous in its presentation. It could be acute and vesicular and erosive, or it could be hyperkeratotic and fissured. And they completely look different and behave differently and may respond to treatments differently. Also, just because one has hand psoriasis doesn't protect them from getting allergic contact dermatitis of the hands. And when the hands and feet are involved, their rates of allergic dermatitis may be higher. Let's look just at palmoplantar psoriasis to start. And these aren't data to memorize, just to give some context. So in this nurses' health study with over 3,000 men and women involved, plaque psoriasis was the predominant form. That should surprise nobody, but the scalp was involved in about half the time, and the palms and the soles were involved 14% of the time. So overall, when we look at studies, about 10 to 40% of patients with psoriasis will describe some form of hand or foot involvement. Now let's flip it around. Let's take palmoplantar psoriasis patients and look at what their demographic is like. So at 59 involving palms and soles, about 20% had palms only, 20% had feet only, and the remainder were both palms and soles. And so if we look at just palmoplantar psoriasis patients, up to a quarter of them may have psoriasis elsewhere. So this can be a very confusing conversation because you really have to decide, is this a psoriasis patient that has palmoplantar involvement, or is this primarily a palmoplantar psoriasis patient that might have some scattered involvement elsewhere? It may influence how you ultimately treat this patient. But one thing is for sure, when you have palmoplantar psoriasis, you already are dealing with a very thick stratum corneum on the palms and soles, which makes the penetration of topical medication very hampered. Now, when we look into psoriasis on the palms and soles, there are subtypes. Plaque psoriasis that looks very much like plaques on the body. This pustular psoriasis of the palms, where you literally see papules or lakes of pus that might make the uninformed provider think that there's an infection, but these are sterile pustules. There's psoriasiform dermatitis. When you biopsy this, it comes back psoriasiform spongiatic dermatitis with elements of both psoriasis and eczema. And then there's the very unusual psoriasis-like eruption that involves one finger, known as acrodermatitis, also known as acrodermatitis continua of Halepo. But you notice the palmoplantar psoriasis patient has many types of presentations, and it may not be so forthcoming on the first visit what that diagnosis is. You really should look at the scalp and the ears and the nails and the elbows and knees to try to ascertain if there's any hints to this patient being a classic psoriasis patient, because just looking at the hands and feet will not deliver the diagnosis that you might want. Regrettably, the treatment for palmoplantar psoriasis can be very challenging. Clearly avoiding irritants that make psoriasis in any location a problem, that's a primary issue. Emollients, very important. Just moisturizing and lubricating the skin not only makes it feel better, it may enhance the penetration of topical medications. And topical corticosteroids are the mainstay of therapy, usually requiring the higher potency steroids to get through that stratum corneum and affect some anti-inflammatory change. Having said that, I think it's easy to forget that when we put super potent steroids on our palms or our hands, it's easy to transfer them up to the face. So we need to have patients cognizant not to transfer this to their groins, to their face, and to their loved ones. Vitamin D analogs with or without topical steroids, calcineurin inhibitors, tar, salicylic acid, and phototherapy all have either case reports or small series in the literature. And of course, now we have newer therapies like tapinarof that we might find use in palms and soles, but it's too new for us to tell that. So here's an example of a patient that I saw with palmoplantar psoriasis. I thought this was palmoplantar psoriasis, well demarcated. That's a good clue when you look for psoriasis. Notice that the plaques are very sharply demarcated, whereas an eczema of the palms and soles has less distinct start and stop areas. I asked this patient to open their hand for the photo, and at that time, his finger split open just from the hyperkeratosis and tension of the stratum corneum. He had failed innumerable high-potency topical corticosteroids, and I put him on acitretin, which I think had a primary effect on the hyperkeratosis, but probably also assisted in the penetration. And this is merely 2 weeks later. You still see the fissure on the second finger there. Hasn't had a lot of time to heal, but we are getting a lot of flexibility back and increased capacity for daily living and work. Apremilast has been described for palmoplantar psoriasis, and this was in the classic dosage scheme of 30 milligrams twice a day versus placebo. And you could see, while there may not be statistical significance early on, see with continued therapy, the placebo and the active group start splitting away. But as you might be familiar with apremilast with just general psoriasis, this drug takes some time to have an effect. And it might be a good choice for patients who don't want to go on a biologic drug, want an oral agent. This was a patient of mine on 6 months of apremilast who got nearly clear. He was a limousine driver that really had a hard time holding the wheel for protracted periods of time and felt this really changed his life in a very positive way. We had this patient in the office with acrodermatitis continua. We could not get control, even with occlusion of super potent topical steroids, and it was interfering with her work and social life, and she cleared using ustekinumab. Regrettably, it's very hard to get a lot of study data on palmoplantar psoriasis, but I've highlighted a few here that I think would be valuable. The Uncover trial relates to ixekizumab in moderate to severe psoriasis. Now, when you look at a sub-analysis of their moderate to severe psoriasis patient entering their trial, 8.5% had palmoplantar disease of reasonable score to include here. Patients with palmoplantar pustulosis were excluded, and you see a number of dosing schemes here, one being etanercept starting out for the first 12 weeks, and of course, the classic Q2 week loading dose for ixekizumab. Then at week 12, everyone folds in to standard dosing at monthly. Now, remember, these are moderate to severe plaque psoriasis patients that have palmoplantar involvement. What we notice here is, one, ixekizumab works on the palms and soles of patients who have moderate to severe psoriasis. It looks like the typical dosing scheme that we would use in regular psoriasis patients worked pretty well. It worked better than placebo, and it worked faster and better than etanercept. And you could see, again, palms and soles may take longer than other body parts to achieve that asymptotic area of the curve where they're getting maximum effect. So I always tell my palms and soles patients that when their body is clearing, their hands and feet may take a little bit longer. A different study called the Gesture trial with secukinumab, another IL-17 inhibitor, looked at palmoplantar psoriasis a different way. Instead of looking at a subcut of moderate to severe psoriasis patients, they looked at patients with just severe palmoplantar psoriasis. So we're starting out and anchoring on the palms and soles, and they're getting either placebo, 150 or 300 milligrams in the standard loading dose sequence that we're used to. And I'm just pointing out here the difference between the ICSI study and the secukinumab study. These patients had moderate to severe palmoplantar disease and needed one plaque outside the palm or sole. So gesture patients would not have been eligible for any of the moderate to severe biologic studies that we see for all drugs in psoriasis. These were specifically palmoplantar disease, excluding palmoplantar pustular psoriasis. And clearly, placebo had no effect. We know this is a very resistant disease, but we see at standard dose, about 40% of patients are getting a global assessment of clear or almost clear as early as 16 weeks. But again, longer time frames are associated with the recruitment of more and more patients with a positive effect. So if you're going to use a biologic drug, and sometimes we need to because of the resistance of this disease and the failure of multiple topical therapies, these drugs have some good sense in using for palmoplantar disease. Pustular psoriasis or pustular palmoplantar disease is probably a different disorder. It behaves differently. It's got some different demographics to it, and it's also different, and it seems to fail to respond to most other therapies where psoriasis, plaque psoriasis, clears very well. So let's look at some data on that. If we look at palmoplantar pustulosis, we notice some very specific issues. Most are current or former smokers. Only about a quarter have coexisting psoriasis. And some of these patients have had a paradoxical reaction that from a biologic drug that caused palmoplantar pustulosis. So you're treating psoriasis with a TNF inhibitor, and all of a sudden you have palmoplantar pustulosis. There was a Cochrane review several years ago looking at the trials of therapies for palmoplantar pustulosis. Systemic retinoids demonstrated some improvement. It's probably one of the main therapies we're still using for palmoplantar pustulosis. PUVA is not something we use very much now, and low-dose cyclosporin had some good evidence for improvement, but not clearance. So I'll often use this when I need to rescue someone who's got really recalcitrant disease. Regrettably, the IL-23s and the IL-17 drugs have showed disappointing results in palmoplantar pustulosis. There are some evolving and emerging therapies specifically looking at palmoplantar pustulosis, and I look forward to future meetings to discuss those. As I mentioned earlier, though, this is a mixed diagnosis often. It's pretty common to have an overlap, and when you're looking at these hands, it may not be so readily apparent what these diagnoses are, and if you'll ever come to a specific conclusion on the diagnosis. Hand eczema and allergic contact dermatitis can be pretty closely correlated with each other. So those that you consider to have a spongiotic dermatitis, a hand eczema, the chances of them having a positive patch test are pretty high. And if you look at the most common allergens that cause hand eczema, there are things that won't surprise you: preservatives, metals, topical medication, and rubber accelerators. These are the really common causes of that chronic hand eczema. Here's a patient who was sent to me with what looked like just really mild atopic dermatitis on the antecubital fossa, a little on the neck. There's always that stubborn finger that you can't get better. And we patch tested her, and look at all these positive reactions. We have methyl isothiazolinone, we have fragrances, we have nail polish, tosylomide formaldehyde resin, and really the avoidance of most of her allergens resulted in near clearance of her eruption. Now, I want to point out that allergic contact dermatitis is not a single disease, and it's not a single pathophysiology. We tended to anchor our thoughts that contact dermatitis was a Th1 disease, right? We certainly think of psoriasis as a Th17 disease influenced by IL-23 and IL-17, but a Th17 disease. And we think of atopic dermatitis as a Th2 polarized disease. But allergic contact dermatitis is not that simple. There are some allergens that provoke Th2 immunity that makes it seem an awful lot like atopic dermatitis, and those that provoke Th1. So we have to keep a very broad mind about how allergic contact dermatitis is provoked and what treatments may influence contact dermatitis in the settings of allergic contact dermatitis. Here's some just interesting cases that I had of a patient with an overlap of eczema and allergic contact dermatitis here. Nickel, lauryl polyglucose, a surfactant in cleansers, and I think an irrelevant one, carmine, which is a red color in cosmetics. Here's a patient with dyshydrotic dermatitis who had dispersed blue allergy in clothes and socks, but really required therapy with dupilumab to get them better. So if we look at the top data for the North American Contact Dermatitis Group Standard Allergen Series, we will see metals, preservatives, and fragrances top the list of all comers for allergic contact dermatitis, but we also see key allergens causing hand and foot eczema right at the top of the list. And if we look at patch-tested individuals, those that have been sent for any reason for a workup for allergic contact dermatitis, we see at the characteristic sites that provoke them to come in, hands and arms are very high on the list. As a matter of fact, hands top the list. They are one of the most common reasons people come in for patch testing. And I'm provoking all of you to consider patch testing patients with stubborn, unresponsive, or recalcitrant hand dermatitis that you think has an eczematous component. If we look at chronic hand eczema, right, we agree that it's got an eczematous component or a psoriasiform spongiotic component, and we take all these patients and look at them after a full workup, including patch testing. We note that for hand eczemas or hand eczema alone, over a quarter of the patients carry a diagnosis of allergic contact dermatitis. When we look at foot and hand eczema, a quarter of those patients have positive patch tests that have a capacity to be relevant. And when we looked at this study from February, very recent, nickel, methyl isothiazolinone, chromium were all important allergens. And those are allergens that you guys can pick up by doing routine patch testing. Hand eczema in children is also associated with allergic contact dermatitis. In fact, those that were referred for patch testing because of involvement of the hands, after they were patch tested, half of them were rendered a diagnosis of allergic contact dermatitis. And what allergens were bothering kids? Nickel, MI, glycols like propylene glycol, desylglucoside, another surfactant in soaps and cleansers, and lanolin in moisturizers. These are common allergens occurring commonly in a common disorder. Let's just dive down, because all of you in the audience here are healthcare workers, and we as a group collectively are at high risk for hand eczema. And hand eczema can be irritant because of constant hand washing. Hand washing is positively correlated with the emergence of hand dermatitis, hand eczema, and irritant hand contact dermatitis. But we also get a lot of allergic contact dermatitis. And when we do, it is to rubber chemicals from our gloves and to preservatives like the formaldehyde releasers and the isothiazolinones and components of hand cleansers. Speaking of rubber, this was a thoracic surgeon who had chronic, recurring, and paroxysmally flaring hand dermatitis, requiring multiple self-treatments with prednisone when he was on call. And here's his back. Most of these patch tests are associated with rubber accelerators in the gloves he was wearing in the office and in the operating room. And when we switched from the accelerators he was allergic to accelerator-free gloves, he cleared. So when we talk about accelerators, what do we mean? What does that term, what does that even translate to? Most rubber is made either from natural latex rubber or synthetic monomers that need accelerators to quicken the polymerization and create rubber. And those accelerators to create polymerization are thiorams, carbamates, benzothiazoles, guanidines, which often co-opt with carbamates, and thioureas. And the thioureas are common in sporting rubber, like handles in the gym or rubber sporting equipment. The carbamates are very commonly used in gloves, whereas the thiorams are less likely to be used in gloves. And that has shifted a great deal in the past decade or two. The key thing is that when you patch test, whether you're patch testing narrowly, like for True Test, or you're using a North American 70 or 80, which I recommend, and rubber chemicals come up as a positive patch test, realize that they are relevant most of the time. It's the easiest thing to dismiss, and it's very hard to chase down, but it is often a common problem. And we need to find products for patients that don't contain the accelerators that they have a problem with. And there are handouts and there are resources out there for that. Isothiazolinones, we speak about a great deal. We are still in a bit of an epidemic of methyl isothiazolinone allergy. If you're using True Test and you just use that Cathon patch test, you're going to miss half, 2/3 of people who are really allergic to the isothiazolinone because the Cathon test is too low a concentration on True Test. We see in certain areas of the world where the isothiazolinones are banned, there's a reduction in the reactivity on patch testing. And the United States, we've throttled back the concentrations of people getting exposed to isothiazolinones. But there's more than just methyl isothiazolinone. There's a newer one, benzisothiazolinone, that has increased in frequency. We'll see if it has a specific impact in hands, but we're noticing it just in general in cosmetics, right? Here's a patient that had a bit of a resistant hand dermatitis. And note, when we patch tested this person, the Cathon test was negative. It wasn't until we tested to the higher concentration, to MI, did we detect it and find clinically relevant allergy in this patient, and they got better. And it was in some cleansers they were using on surfaces and putting their hands on. Isothiazolinones also find themselves in quirky locations, like this vacuum pump. I think initially the impressions are it's the adhesive or it's a part of the device that may have plastic or rubber, but these preservatives make their way into some of the strangest areas. Fragrances, we know, are present in cleansers. They're present in moisturizers. They are some of the most common causes of contact dermatitis. It's constantly shifting. Certainly use the fragrance mix one, the Balsam of Peru fragrance mix 2. But if you're really getting into a good hand dermatitis workup, or you have an interest in allergic contact dermatitis, do stay on top of the emerging fragrance allergens like linalool and limonene, and some of the natural fragrances like the mosses, the oak moss, the tree moss, the cinemates, that can frequently provoke allergic contact dermatitis, particularly on the hands. I didn't want to leave out the feet. Working up foot shoe-induced dermatitis can be a little tricky. I have some very recent data on the top allergens causing foot dermatitis, and the chromates, which are used to tan leather, are very important and shouldn't surprise us. PTBFRs, paratertiary butylphenyl formaldehyde resin. That's a glue that's frequently, a flexible glue, frequently used to bond leather together. It's also used in belts and wristwatch bands. We see the thiorams and the thiourea and the carbamates. We heard about those with hands and rubber with gloves. We're seeing them in shoes, and they're causing hand dermatitis. But what's something different about shoes is people will put medicines on their feet and then stick their feet in the shoes and contaminate those shoes forever, right? Here's a really interesting case of a foot dermatitis, right? And they deconstructed those sandals. The patient wasn't allergic to the sandals at all, but they're allergic to an antifungal cream that contaminated the leather and was constantly re-exposing the skin when the patient put the sandals back on, right? Once you've put a foot with a medicine or an allergen into a shoe, that shoe becomes the reservoir for that allergen for all time, right? So is there value of cutting up shoes and shoe parts when you're working up a foot dermatitis? And this recent study would suggest that your baseline series can and will find some relevant allergens, but there are some sleeper allergens out there that you're going to miss. And what I find pretty useful is the 6 or 8 millimeter punch biopsy, not into the patient's foot, but into different parts of the shoe. And then you could patch test to those shoe components, or use a bandage scissor and cut shoe components up, wet them with a little saline, and put them on the back with some tape for 2 days and see how they react. Lastly, stubborn hand and foot dermatitis. It's the time we do think about systemic allergic contact dermatitis. This patient came into me and really suspected food was a problem. In fact, she did have a nickel allergy and felt that reducing her oral nickel intake did improve her hand dermatitis, right? And it's always a little tricky on when we bring that in. But systemic contact dermatitis is when patients are taking an allergen systemically, not on top, but they're eating it, it's being infused, it's being injected, it's being inhaled, and it manifests in a remote part. For metals like nickel, palms and soles are the common presentation. And maybe one in 5 to 1 in 10 or 20 patients with a good nickel patch test might find provocation from a high nickel diet. And there's resources out there that talk about what foods contain a lot of nickel, and you could feel free to reach out to me for some of those as well. So hand dermatitis, it's a heterogeneous disease. It could be all the way polarized to psoriasis, all the way polarized to endogenous eczematous dermatitis, to blends, to exogenous causes like contact dermatitis. The treatment's going to rest in the diagnosis. You have to commit to some point, but then we're going to use all of the classic treatments that we use for eczema, whether that's topical therapies, biologic therapies, oral therapies for eczema and psoriasis to get this under control. And when you think it's eczematous and it is resistant, consider patch testing to help get a little bit more information on things that might be making that patient worse. Thank you so much for your attention, and I look forward to seeing you at future meetings.